First of all, I want to introduce our two panelists. We have Shannon Wedekind. He's the pharmacy supervisor for Walgreen. He's a pharmacy executive based right here in Orlando, and he's been instrumental in expanding the role of pharmacists throughout Walgreens by increasing cognitive and patient care services. We also have Kevin Kuhlman. He's the manager of legislative affairs for NFIB, and he serves as their manager of legislative affairs for the U.S. House of Representatives and focuses his advocacy on healthcare services. So we're in good hands. Gentlemen, while there is a lot of focus on government, and certainly this year everyone's looking to what state and federal governments will do, while the government acts or doesn't act, there's a lot of innovation happening in the private sector. So to start the morning, I would like each of you to talk from your perspective about what do you see as the two most promising and proven private sector innovations that everybody in the room should know about and embrace. And we'll start with Kevin.
Great, thank you, Tarren. I think kind of where we see the market going, granted there's a recent law passed that may prevent that from continuing to going full bore soon, but is an embrace of more of the consumer-driven healthcare, allowing employers to kind of better control and predict their costs, and employees to truly kind of control and choose what's best for them. And piggybacking off of that, I believe that moving more towards a defined contribution health insurance system might be a way to go. But that first point on the consumer-driven health care, the adoption of high deductible plans has just been tremendous, both from an individual and from an employer perspective. In 2006, 4% of employers embraced some sort of consumer-driven health insurance. It's now above 30% and continues to increase rapidly. The gross numbers are from, a couple million tiptoeing into it about 6 years ago to many people realizing this is normal and this is good. And I don't think it's the panacea and it's not solving anything, but it is helping a little bit. And I think in the most recent Kaiser Family Foundation survey on health trends that they have and the health insurance survey they did, they kind of came to that conclusion. They said, listen, the massive embrace of these is a contribution. It's not the full answer to it, but it's definitely contributing to lessening of the increase of costs. It's not driving costs down necessarily, but it's helping on reduce the increases, I think you should say. Then the second point I talked about was kind of the defined contribution style. This is kind of more available for larger self-insured firms. You saw and it's allowing employers to give a defined amount and then allowing their employees to go to some sort of private exchange and allow them to pick out a plan that best suits their individual needs. Down here, you saw and there were stories a couple months ago about Darden restaurants moving to embrace something like along these lines. So it exists now kind of for the larger folks. I'd like to see that come down to the smaller employers, mainly the NFIB members. That might take a little bit of federal and state regulatory or legislative action in order to allow that and better assist that and spread that. But I think that's kind of two things that I've noticed that are helping. And if it continues that way, I think we'll continue to see the increases become less and less.
Shannon?
All right, so from a private sector or retail perspective on solutions, I think we first need to start on what we know. So right now what we know is that 92% of Americans live within 5 miles of a retail pharmacy or a community pharmacy. In Florida, that's 90% of the population lives within 5 miles, or on average 1.86 miles. Also, if you speak about minorities, 93% of African Americans live within 5 miles of a Walgreens. 95% of Hispanics live within 5 miles of a Walgreens. So that's access. you also know that every week you visit a retail or grocery store about 2 times. So if you think about access to care, and you think about all the problems we're talking about with overall healthcare expenditures, there's only probably 2 groups you might visit more: your family and friends, and where you go to work every week. And you go and see a community pharmacy, whether you go and see them specifically or you enter their facilities, twice a week. So that's access. And that drives where should we spend and focus on some of the energies for the solutions we're looking for. So we can leverage that high touch or high access point to help deliver healthcare in a different way. So if we're here today and yesterday to speak about how we're going to change things, well, we got to know where those points of interest might lie. And we believe in community pharmacy, it lies with us because of the point of care and access that we have. So there's a couple of different ways to do that. And yesterday they talked a little bit about incentivizing patients through co-pays or a wall, like an internet shopping mall of sorts when you accumulate points. And there's also ways to incentivize patients within the pharmacies. So if I have to go and see the pharmacist because I have heart failure, I have diabetes, I have hyperlipidemia, high blood pressure, and payers incentivize patients to go to a pharmacy and help manage their disease state, you're going to have better outcomes in the sense that you're going to have more influence. So if I go to a retail or grocery store twice a week, do you think if I interact with a pharmacist, I'll have more leverage as a pharmacist with that patient than if I go to other providers once a year, twice a year? I mean, I know our employers influence us on how we do our jobs. I know our families influence us on how we interact. Our pharmacists, they're the most trusted profession for several years going, top 3. And I think we need to leverage that and understand that the pharmacists are experts in drug and disease state management. That's what we went to school for. We didn't go to school to count pills. That unfortunately has become part of the history of that. But you need to leverage what the pharmacists are coming out of school today to do, to help manage collaboratively the patient's care. So how do those access points affect solutions? So I can talk about from a retail perspective and then obviously more inclusively with Walgreens are some of the options that we believe we can do. So chronic disease state management. So if a payer defines who the most cost is expended with, then create a portal where those patients are identified and they need to go and have a high touch point with a pharmacist. And then have whatever the measuring or portal or software you want to identify those pieces and how the outcomes have improved so I can reduce overall health care. Preventative health care, like giving free flu shots today for you as a benefit, but obviously they're not free unless the plan design is for that. So that, like JD, he can make the panel today, right?
Do they work that quickly?
Within a week or 2, you're good to go, for sure. The other part is the healthy living style. So if I interact with a pharmacist and we talk about the barriers or the interferences in your life that prevent you from taking your medication or side effects associated with it or the socioeconomical standpoint from that, we can make an impasse on them actually taking their medication. Because not all of them, the doctor writes the prescription, doesn't mean it actually gets to the pharmacy for one. And once it gets there, about 30% of those are rejected because it's not covered, it's prior authorization, step therapy, whatever, mind you. And then it's that interaction back and forth between the physician and the payer on how we're going to get the solution for that patient. So, and that's a whole other piece with health information technology. But there's more to it than that. It's about counseling the patient on medications, about changing behaviors, and then, the payer incentivizing those behavior changes as well. But our interaction with that can help influence and help change those behaviors through our high touch point and consistently touching those patients up to twice a week. those make differences, because it's easy to be told something and then, yeah, I'll get to it. And you kind of forget about it because something else comes up in your life. Pharmacists have that ability to change that because we're going to have those interactions. So how do we change the model then? So within Walgreens, and I'm sorry if I'm going on, but I've got space here with JD missing, so I'm going to continue to talk.
If I give you the space. If I give you the space.
Thank you. So part of that is where we believe in a retail pharmacy or community pharmacy, and especially at Walgreens, how can we be a solution to the overall healthcare cost? How do we lower that cost? How do we change the payer system? So we believe in it so much as a retail pharmacy at Walgreens that we've decided to create a well-experienced model in a lot of our stores, and it'll continue to expand going forward in the state of Florida specifically, so that we will leverage technology, leverage some of the legislation that's already in place to allow our pharmacists to be removed from more the administrative task of this pill is in this vial and those kinds of things, either from a distance through a centralized pharmacy operation, using electronic information to be moved from one place to another so that other pharmacists and technicians can do those things, but that allows the pharmacist in the community pharmacy to have direct interaction with the patient, to change those behaviors, to counsel the patient on the medication. And it's far different doing that at the cash register, the point of sale, and then actually removing them from that line outside of the space so that the patient can walk up to the counter and have a pharmacist sitting there to be able to interact with. To have a seat. Let's talk about your medication profile. Let's talk about all the things you take that maybe we don't see here at Walgreens because you go to Publix and get a free antibiotic, and so it's not in the system with a PBM. You go to Walmart and you get a $4 generic, so it's not in the system. So I don't have purview as a PBM and thus as Walgreens to be able to see those pieces.
So Shannon, just to look at proven solutions, so do you have like pilot experiences or programs at Walgreens as you're talking to the audience that here's a disease management strategy that we tested, it worked really well, and this is why other people should embrace it? Right.
So most of this is ongoing. We kind of put the cart before the horse. So we're betting on some of these pieces because we believe as pharmacists that that's where we can make an impact. I mean, that's why we went to pharmacy school, is to make a difference. And to work for an employer that believes and embraces that is wonderful, and that's why we're here.
What about,
as far as so the pieces that we're doing, so we have in Florida what we call a power model, which leverages the ability through legislation and through the Board of Pharmacy for us to have information move from a pharmacy to a centralized operation so that technicians can type the orders from the prescriptions. So the pharmacist there can just focus on data review of a prescription. That's what the doctor wrote, that's what the tech wrote, and it makes sense. And then a DUR analysis as well from another pharmacist. So it's just focused. You imagine, going to the pharmacy, you see the pharmacists being pulled everywhere, right? They're doing everything. They're answering all the questions. And so if you limit that interaction and that interruption, you also improve quality, right? From a mistake standpoint. So, and it also allows, when I come to the pharmacy, that I get the undivided attention of the pharmacist to help me through that process of healthcare.
A lot of times in the private sector, you're looking at different types of solutions and innovations, and yet government gets in the way of those solutions ever being born or being fully realized. So pretend you don't have your current job and you're a benevolent dictator for a day. What are the 2 legislative or regulatory changes that you think lawmakers in Florida today, or the governor today, should pursue that would support exactly what kind of innovation that's being held back? So you're a benevolent dictator. What are the couple things that you would change in statute or in regulation, and how would that unleash a solution that's held back today? Kevin?
First, I would institute Pizza Friday. And then, more seriously, I think, I'll speak more generally than Florida once again. It's, if we're able to unleash kind of competition a little bit more, if residents of Florida are able to go look for a plan that maybe is more affordable or at least inserts a little competition in a different state, I think that would be interesting. You don't want to totally dismiss the regulatory process and have a race to the bottom, but I don't think that would occur if you allowed for a little
what are you
interstate
thinking
competition.
about? Like if there's a lawmaker sitting here, what's the bill they should introduce?
Well, there's this idea of interstate compacts for health insurance. It hasn't really caught fire yet. I know Georgia has passed one, and it hasn't been as overwhelmingly popular as it is. But as I said, there's the willingness right now to for folks to look at new opportunities and that type of thing. And I think it maybe with more education and outreach, it could be an opportunity if it were allowed to, any sort of compact is really handcuffed by the federal government as well. Really don't have a lot of options, but more for a potentially very high benefit mandate state. You look at a place like New York, New Jersey, Massachusetts, a lot in the Northeast where there are a lot of state mandated benefits. I think, and the folks have really, really high health insurance costs. I think that, infusing a little competition in those states would definitely help. Another thing is I would caution towards, states we're supposed to name an essential health benefits package. This is the health insurance benefits and service, covered benefits and services that all individual and small group market policies must offer beginning of the year 2014. And more than half the states defaulted to the federal government, so the federal government will have this default EHB. I just think this is, this will only have an additive property and will only increase costs. I think both at the federal level, that's something that should be revisited, and at the state levels, it may be kind of as an oversight angle, just take a look at what specifically the essential health benefits package that only applies to the individual and small group market, what impact that will have on premiums for that market, those markets that really need the most help, the most relief right now.
So specifically on that question, is there the ability of states to go below the federal floor? Is the federal government acting as a floor or a ceiling when it comes to setting that standard? And again, in your benevolent dictator rule, what would you suggest the state do?
I would. I think it's good that Governor Scott is interacting with the federal government and engaging in the process. And I don't know if there's going to be any willingness to move on that, but he's engaged. He's not like some other leaders who are just saying, we're not even going to engage in the process. I think it'll be more productive as an interested party, at least exchanging letters, trying to get questions answered. But if I were the benevolent dictator, if you will, I would say I would try to just infuse more competition in, like I said, and lower the regulatory burdens. And specifically, I would identify that essential health benefits package to start, because at least giving it, a thorough examination, cost-benefit analysis study of many of the mandated benefits. It acts as a floor, I guess, to answer your question,
okay.
But the ceiling isn't very much higher.
The federal government acts as a floor.
The federal government acts as a floor,
okay.
But it is a floor that's been raised, I guess you could say.
Okay.
Yeah.
I understand. All right, Shannon, so you're a benevolent dictator with a point of contact within 5 miles of 90% of the population, which seems like a nice combination. What would you do?
Well, a couple things that we would need help from the Florida legislature and the Board of Pharmacy would be allowing the pharmacists to actually practice at the highest level of their profession. And that is done so by loosening some of the regulation around the pharmacy technician ratio to pharmacists. So right now in the state of Florida, the standard is 1 pharmacist per 2 technicians they can supervise. And we do an exceptions in Florida, and we're allowed at Walgreens at least, and I'm sure many other retailers, where you can have 1 pharmacist to 3 technicians. But to allow me to be moved from a lot of that administrative task, I need some more helping hands, right? So that I can have that interaction with pharmacists on a larger scale.
And other states do that?
Other states do that at different ratios. Some are 1-to-1, unfortunately, and some are a lot larger. So it doesn't have to be a carte blanche. It could be where you decide based upon the technology and the things you're leveraging from a board of pharmacy perspective on who you limit that access to as far as how many technicians they could manage or supervise. So we use a lot of technology in our pharmacies to allow us to streamline and become more efficient so we can spend more time with patients. So maybe you don't just give it out, but you ask for the exception, in the state and the board of pharmacy to allow a 5-to-1 ratio. Let's, make an upper limit, that's fine, but give us more space to be able to care for patients better.
A second thing, regulatory or statutory change?
It would be regulatory in the state and then board of pharmacy rules and regs. So the second thing, and I don't know if there's much appetite for that, but maybe by 2015 it would be on providing more immunizations in the state of Florida. So right now we can provide flu shots, which you know about today, pneumonia since July of last year, and the shingles, Zostavax vaccine since July of last year. So, several years ago when we got the ability to provide immunizations for flu shots, Florida ranked 48th out of all states, the continental United States, in immunization rates. And 3 years later, we were 4th in the nation on immunizing our population. That's a huge turn in protecting our patients and our population of the state. So the average pharmacist or the pharmacy allowing pharmacists in states, it increases immunization rates by 5 to up to 10% of the population because of access and administration ease, as you see here today. The other part is the CDC says for every dollar invested in immunizations, you save over $10 in overall costs. So in other words, $42 billion a year are wasted because we don't get immunizations or allow our patients the ability to walk into a retail pharmacy to get immunized on preventable disease states. So we believe it's important. In New Mexico, they have a broader authority to provide immunizations, and their immunization rates are in the 80 percentile, whereas across the United States, it's around 55%. So once again, access, solution is retail or community pharmacy, and we need the payer support to allow for that, and then obviously the authority from the state to provide those vaccines to protect our citizens.
And you're suggesting that it's probably worse to get the disease than run the risk of getting the shot at the pharmacy versus your doctor?
Oh, yeah. I don't know if you've seen some of the shingles pictures that we have, or if you have any family members that ever had shingles before. It's pretty bad. My wife had it when she was 25 and pregnant with our firstborn child, or 28 rather, and it was painful. And the bad thing is it can be recurring as well. So if you've had chickenpox, you're likely to get shingles. But some of the threshold there is payer and dollar spend on the actual cost of getting it versus long-term consequences for getting shingles or any other disease. Tdap we can't do, meningitis. Think of all the students that go to college that get meningitis and pass away, unfortunately, way younger than they should have. There's a lot of simple immunizations in the terms of being inoculated to prevent those things from happening.
I remember along that lines going to a travel clinic before my wife and I went on a trip to Africa, and we were asking the guy, should we really spend the $60 for the yellow fever shot? And he's like, no, not at all. Let me just read to you what will happen with yellow fever, and then you decide. And we grabbed our wallet pretty quickly and willingly paid.
Good.
I don't think he was just a tech. But anyway. All right, so now the opportunity is for you to predict the future. So we have really some of the biggest changes in the healthcare system from a coverage standpoint, but also from potentially a healthcare delivery standpoint that will be rolling out upon us over the next couple of years. So let's fast forward and pretend that we're all here again in 2016, 2017. We've had a year or two under the ACA, Obamacare, whatever you want to call it. Predict what is the landscape going to look like, and how should that cause us to act differently today? And we'll start with you.
Okay. So a couple of things. One would be the ability to transform our pharmacies and allowing that access of care, and identifying patients that have the highest spend to come into the pharmacy and have a higher touch point and communication on their disease state so we can collaborate with the physicians. In order to do a lot of those things, we have to use the technology that's available. So having a single platform to be able to transfer information from one provider to the next. So from the hospital to the private sector, to the private sector being community pharmacy, to the physician's office or to specialists, we should be able to see all that, even if they pay cash for it, even if they get a $4 generic, even if they go get a free antibiotic. Whatever the landscape looks like, that should be brought in within the system so that we can see that and better manage our patients, because you need purview into what they're taking. So that's definitely one piece of that. The other part is allowing more authority for the pharmacists to provide immunizations to decrease waste and harm to our patients because of getting immunizations that they should have gotten. But because of the access to care or because of our ability to provide those shots, it's limited from that. A couple other pieces maybe I didn't touch on that I'd like to, if you don't mind,
Sure.
prior to that. So I'm not running for candidacy or anything, but I want to circle back to the previous question.
You want to be benevolent dictator a little longer?
Sorry.
No, I don't mean
good
that as
feeling
cutting
once
you
you,
off.
yeah.
But you have
Yeah.
some other
The
ideas.
power
start,
of the
you can't
table, the
stop.
mic, yeah.
Yeah.
On the opening statements of this actual convention, the speaker spoke of where the most costs are, and that retail clinics were just a small potatoes. But if you look at access to care in the physician's office, if they have a traditional 9 to 5, that doesn't really work with most families that work 1 or 2 jobs. So having a take care clinic, as in with Walgreens or any other clinic that's out there, or if it's even a part of a hospital for Centric Care or those kinds of things in Orlando, you allow greater access to care that prevents them going into ER and having 3 or 4, 5, 6 times the spend. So if it's an earache that I can't get into the doctor because they're booked, right? I can go into a take care clinic and be seen that day. I can make an appointment online, show up, and be seen, and my child's fine. I don't have to take a day off to go to the doctor, right? It works with me. So I'm more likely to see that care early on before my toothache is totally inflamed, right? And I've got to take my child to the healthcare ER. The other part is Employee Solutions Group. And you heard of another panelist yesterday speak about the clinics he has, throughout the country. And we also have that within Walgreens as employee solution groups, and one of them is a big mouse that's nearby called Mickey Mouse at Disney. So they have Take Care manage their full-time beneficiaries in the parking lot of Epcot for the employer's parking lot. They have a facility in which Take Care is the solution for decreasing overall healthcare spend for Disney. And so we have a full boat medical team, full house pharmacy that we operate, and then you also have behavioral health and various other nurses that assist in the long term. So they're actually able to target the patients that are the highest spend and manage them within that facility or outside, but they incentivize them through additional consultations, through additional services, through additional testing. And if you're diabetic and you sign up for the plan and you do what you're supposed to do, your copays are free. And you get it for 90 days. And just because you get the prescription filled doesn't mean you take it. So you need someone to be there that you trust to talk to about your medication. What are the barriers? What is the interference preventing you from taking your medication? So it's a combination of incentive, but also aligning where your trust is and who you have the most interaction with is your pharmacist. And we can make that difference, and I think we have, but it hasn't been really pinpointed on where's the highest spend and who should we best manage and leverage that pharmacist and access.
Kevin, in the small business landscape, say it's 2016, give us the good, the bad, and the ugly of what that looks like.
I'll start with the good, because I think it may be brief. I'm kind of kidding. But as I said, there is this, I keep going back to it, there is this interest and this awareness kind of right now for both employers and employees. They are very interested in especially the small business owner. What does this mean for my business? More importantly, what does this mean for my employees? How can I help translate this to them and figure out what it means to me as well, and what are my options? And that appetite is especially true right now. There was, maybe for some, they were holding out on the Supreme Court lawsuit last summer. Okay, the law survives. Then maybe potentially the election. Okay, the law survives. So here we are. Here is reality, and we're kind of deeming 2013 the year of determination. One, because it's going to take a lot of determination to kind of figure out what this means. But two, you have to determine if your employees are full-time or part-time. It seems like such an easy concept, but 144 pages of regulation just on that specific topic makes it a little bit more complicated, and you have to determine whether you are a large or a small employer. Again, something that seems so easy, and it's really quite difficult. So because but I said I would start with the positive. I think there is an opportunity to truly educate employees to be a little bit more sensitive to the cost and the ever-increasing cost of providing health insurance coverage. One potential opportunity, although it's been delayed, there was a provision in the law that will require employers to report the cost of providing health insurance both to the employee and the employer on their employee's W-2. That second challenge would just be to get employees to focus on their W-2 a little bit more. But right now that's only required for businesses with above 250 W-2s, but the law says that'll come down later. We're still waiting on further regulations. So there might be an opportunity to learn a little bit more there. And maybe that will help. You can use that as a tool to educate and try to guide folks towards, as I said, the market may continue towards to embracing more consumer-driven health insurance. There was some concern that the law would endanger these products. There are deductible limits within the law. Some reasonable or sensible regulation occurred that said, okay, if a policy is unable to meet that deductible limit while still also meeting that other requirement of 60% actuarial value or minimum value, then we'll waive that deductible limit. You can't exceed it. That was a positive, so that'll allow these products to continue to exist.
And the bad and the ugly?
I think, from the employer side, they will definitely look towards their other options. Maybe, like I said, more of the consumer-driven, but another opportunity may be examining self-insurance. There are a lot more requirements on, and whether it's increased mandates, taxes, or fees on fully insured products versus self-insured products. We're not advising anybody to self-insure, but I imagine folks will meet with their brokers and maybe their attorneys or accountants and examine that option. It's obviously taking on potentially more risk, but it might make sense for some folks. Now, there are some states, and I think we'll touch on this later, some states that are looking to limit that a little bit more. I would advise against trying to limit that because, again, allow small businesses to have the same opportunity as larger businesses. I think that would be valuable. I do predict increased premiums, especially for small businesses. I covered that essential health benefits package earlier. There is this, what we're calling the small business health insurance tax. It's a tax on insurers and only on fully insured products, which is about if businesses under 50 employees provide insurance, about 90% are providing this fully insured product versus self-insuring. But that's going to increase premiums by about $400 in the year 2016. So I think that'll increase a little bit more. There's actually a good article in the Politico today by Jennifer Haberkorn, and it's titled "Insurers 2014 Hikes Already Taking Its Toll." Those are starting to be built into small business premiums already. I think you could see, there is some, because of the uncertainty and maybe a little bit of fear of the employer mandate, you may see some dumping immediately. I think a lot of people will explore their options fully before they make that decision, but it might not be their decision to make. If your competitor decides to dump because of anything from a political decision, a worried reaction, or that's just what they deem best for themselves, then that may force your business to dump. But especially, I think, a resistance to grow. That 50 full-time equivalent employee threshold is going to be especially important if you're in that 40 employee to 60 employee sweet spot. I think those folks are very nervous right now. That's the threshold that the employer mandate does kick in. I think they're going to explore any and all options. The regulation on the employer mandate that I just raised earlier, it just came out on January 2nd, and it's very technical, and it provides some clarity, but also some confusion for those folks who don't have large legal and HR departments to figure this out. And then, and on the provider side, I guess small business will probably hope for some clarity and sensibility in pricing, and that's kind of occurring at the retail pharmacy level, the community pharmacy level. But yeah, and I hope from a government perspective, maybe from a collaborative effort, state and federal government, I hope for some sensible relief, some sensible protection for small businesses in order to ensure that there isn't a massive erosion in employer-sponsored health insurance.